making it impossible to follow up. There are also statistical limitations to VAERS. VAERS does not collect data on the number of vaccine doses administered, so actual rates of adverse events cannot be accurately calculated. Finally, it is important to keep in mind that VAERS is not designed to assess if a vaccine caused an adverse event. Coincidental events are reported to VAERS that happen at the time of vaccination and are related to other causes. VAERS does not make an evaluation of whether reports are caused by vaccine. However, these coincidental reports remain in its public searchable dataset, CDC Wonder. Let's discuss the uses of VAERS. VAERS can be used to monitor the general safety of new vaccines. During the 2009 H1N1 influenza pandemic, VAERS was key in helping to assess the safety of the H1N1 influenza vaccine. VAERS provided the first national data during the H1N1 pandemic, and this information was useful to vaccine policymakers. VAERS can also help to detect new adverse event signals. Signals are detected when the number of reports of an adverse event is disproportionately larger than similar reports after other vaccines. Signals are further evaluated by more rigorous research. For example, in 1999, a rotavirus vaccine was found to be associated with an increased risk of intussusceptions, a serious medical condition in which a part of the intestine telescopes into another part of the intestine and can result in bowel obstruction. This rare risk was identified because 15 healthcare providers took the time to submit a report to VAERS. The manufacturer voluntarily removed the vaccine from the market until further studies confirmed the finding that there was a risk for intussusceptions. Today we use an entirely different rotavirus vaccine. A condition that is not so rare is syncope following vaccination. VAERS detected a signal of an increased risk of syncope in adolescents after receiving vaccines, especially in females receiving Gardasil vaccine. This led to recommendations regarding observation of the patient after vaccine administration. VAERS data can also provide reassuring information supporting vaccine safety. For instance, in 1976, vaccination with the swine flu vaccine was associated with Guillain-Barré syndrome, or GBS. VAERS has monitored influenza vaccines every year looking specifically at reports of GBS. The results have been reassuring, and only a few studies have suggested an increased risk for GBS after influenza vaccines since 1976. The studies suggest that if there is a risk for GBS after influenza vaccine, it would be about 1 additional case per million persons vaccinated. In another example, VAERS was able to document a decrease in the reports of fevers and seizures when the newer acellular pertussis vaccine, DTaP, first came on the market as compared to the older whole cell pertussis vaccines. So as the cornerstone of the country's vaccine safety monitoring system, VAERS is always on call to receive reports of any adverse event suspected to be related to any U.S. licensed vaccine. There are a few important points to remember. VAERS accepts all reports of adverse events. Events that are related, as well as those that may seem unrelated to vaccination, can be reported. A report in VAERS concerning an adverse event does not prove that the event was caused by the vaccine. The event may be coincidentally related to vaccination. VAERS reports are screened and evaluated on an ongoing basis by teams of researchers at CDC and FDA. Vaccine safety concerns are identified and further assessed, as illustrated by the example of intussusception. VAERS relies on the astute healthcare provider, as well as patients and family members, to notice and report adverse events that may be related to vaccination. Your contribution to VAERS is absolutely vital. VAERS cannot work without you.
VAERS is a critical tool in CDC's vaccine safety surveillance system. However, it does have limitations. An important limitation of VAERS is its data cannot be used to determine whether a reported adverse event was caused by the vaccine. This cannot be determined because VAERS contains no information about the occurrence of medical conditions or symptoms in persons who are unvaccinated. To obtain these data, it is necessary to study a large population that contains both vaccinated and unvaccinated persons. In such a population, the medical condition or symptoms that may indicate a vaccine adverse event can be counted, and the rate of the condition can be compared for both vaccinated and unvaccinated persons. If a medical condition or symptom is significantly more common in the vaccinated group than in the unvaccinated group, this suggests the vaccine might be responsible. The gaps that exist in the scientific knowledge of rare vaccine side effects prompted the CDC to develop the Vaccine Safety Data Link, or VSD project, in 1990. The VSD project involves partnerships with 10 large health maintenance organizations to continually monitor vaccine safety. VSD is an example of a large linked database and includes comprehensive medical and immunization histories for more than 5 million people. All vaccines administered within the study population are recorded. Available data include vaccine type, date of vaccination, concurrent vaccinations, those given during the same visit, the manufacturer, lot number, and injection site. Medical records are then monitored for potential adverse events resulting from immunization. Since VSD includes medical records of both vaccinated and unvaccinated persons, rates of medical conditions can be generated and compared. The VSD project allows for planned vaccine safety studies as well as timely investigations of hypotheses. The database is also being used to test new vaccine safety hypotheses that result from the medical literature, VAERS, changes in the immunization schedule, or from the introduction of new vaccines. This project is a powerful and cost-effective tool for the ongoing evaluation of vaccine safety. We will include links to VAERS and additional information about the Vaccine Safety Data Link and other vaccine safety resources on our Updates and Resources webpage.
Vaccine administration is a critical component of a successful immunization program. The recommended route, site, and dosage for each vaccine is based on clinical trials, practical experience, and theoretical considerations. Vaccines may not protect your patients if they are administered incorrectly. All staff, permanent and temporary, who will administer vaccines should receive competency-based training and education on vaccine administration before providing vaccines to patients. Staff knowledge and skills should be validated with a skills checklist. All staff should receive continuing education when there are new schedules, vaccines, or recommendations. The rights of medication administration should be applied to each encounter when vaccines are administered. These rights include the right patient, the right vaccine or diluent, the right time, which includes administering at the correct age, the appropriate interval, and before the vaccine or diluent expires, the right dosage, the right route, needle length, and technique, the right site, and the right documentation. Deviation from the recommended route could reduce vaccine efficacy or increase local reactions. So let's talk about route, needle length, technique, and site. There are 4 routes used for administration of vaccines: oral, intranasal, subcutaneous, and intramuscular. Rotavirus vaccines and an oral preparation of typhoid vaccine are the only vaccines licensed for use in the U.S. that are administered by the oral route. Each rotavirus vaccine has a different presentation, but both are administered by the oral route. Unfortunately, we have heard too often about rotavirus vaccine being injected into an infant. There is only one vaccine currently administered by the intranasal route. That is the live attenuated influenza vaccine, or LAIV. Unfortunately, we have also received several reports of this vaccine being injected. There are no safety or efficacy data for LAIV or rotavirus vaccines administered any way other than the recommended route. Doses of these vaccines administered incorrectly are invalid and must be repeated. Most vaccines in the United States are administered by injection. Subcutaneous injections are administered into the fatty tissue found below the dermis and above muscle tissue. Subcutaneous tissue is present in most areas of the body. The recommended subcutaneous sites for vaccine administration are the thigh of infants younger than 12 months and the upper outer triceps area of the arm for older children and adults. The upper outer triceps area can be used to administer subcutaneous injections to infants. The recommended needle size for subcutaneous injections in all age groups is a 23 to 25 gauge 5/8 inch needle. A longer needle could penetrate the muscle, particularly if given at an incorrect angle. To avoid reaching the muscle, the fatty tissue is pinched up and the needle is inserted at a 45-degree angle. A more perpendicular approach is used for an intramuscular injection. The majority of vaccines administered by injection are given by the intramuscular route. Incorrect intramuscular technique can reduce vaccine effectiveness and increase local adverse reactions, so proper technique is critical. Intramuscular injections are administered into muscle tissue below the dermis and subcutaneous tissues. The amount of overlying subcutaneous tissue depends on the person and the site. Although there are several IM injection sites on the body, the routinely recommended IM sites for vaccine administration are the vastus lateralis muscle in the antilateral thigh and the deltoid muscle in the upper arm. Injection at these sites reduces the chance of involving neural or vascular structures. The site depends on the age of the person and the degree of the muscle development. The deltoid muscle is most commonly used in older children and adults. The deltoid muscle can be used in toddlers if the muscle mass is adequate. It is important to use anatomical landmarks to locate the site so that the injection is given into the center of the muscle. The gluteus should not be used as a site to administer vaccines. Injection in the gluteus risks injection into the fat or damage to the nerve tissue. A 22 to 25 gauge needle is recommended for intramuscular injections. The needle length must be adequate to reach the muscle and is based on the size of the individual. A 5/8 inch needle may be considered for newborns in the first 28 days of life and preterm infants. The recommended needle length for an infant is generally 1 inch. The recommended needle length for older children can range from 5/8 to 1 1/4 inches, depending on the injection site, the size of the muscle, and the thickness of the fatty tissue at the injection site. A 5/8 inch needle is adequate only for the deltoid muscle and only if the skin is stretched flat between the thumb and forefinger, and the needle is inserted at a 90-degree angle to the skin. A longer needle should be used for the anterior lateral thigh. For adolescents and adults, the deltoid muscle is the routinely recommended site, although the anterior lateral thigh can be used. The needle length generally ranges from 1 inch to 1.5 inches, depending on the person's gender, weight, the size of the muscle, and the amount of fatty tissue at the injection site and the technique used. This can all seem rather complicated. Fortunately, there is a table in the 2011 General Recommendations on Immunization, Table 10, that lays all this out. It is yet another reason to get a copy of the General Recommendations. To avoid injection into subcutaneous tissue, the skin of the selected site can be spread taut between the thumb and the forefinger, isolating the muscle. Another technique, acceptable mostly for pediatric and geriatric patients, is to grasp the tissue and bunch up the muscle. The needle should be inserted fully into the muscle at a 90-degree angle. Remember, injection technique is the most important parameter to ensure efficient intramuscular vaccine delivery. This is a list of vaccines that should be administered by the subcutaneous route. Vaccines given subcutaneously include measles, mumps, and rubella-containing vaccines, either as trivalent vaccine or in combination with varicella vaccine, meningococcal polysaccharide, varicella, zoster, and yellow fever. This is a list of vaccines that should be administered by the intramuscular route. Vaccines given IM include anthrax, any product containing diphtheria, tetanus, and pertussis, Haemophilus influenza type B, hepatitis A, hepatitis B, inactivated influenza, pneumococcal and meningococcal conjugate, rabies, Ixiaro brand of Japanese encephalitis, and typhoid VI vaccines. 2 vaccines, inactivated polio and pneumococcal polysaccharide vaccines, can be administered by either the subcutaneous route or the intramuscular route. For these 2 vaccines, neither the vaccine manufacturer nor ACIP recommends one route or the other. With IPV and pneumococcal polysaccharide, the clinician can choose the route. For all other vaccines, the manufacturer's recommended route should be used. There are a few other issues related to vaccine administration that seem to generate a lot of questions. Donna will review these.
Other important vaccine administration issues include infection control sites for simultaneous administration and latex allergy. Hand hygiene is recommended between each patient. When working at a site where it is not feasible to wash your hands before each patient, an alcohol-based waterless antiseptic can be used between patients and in situations where your hands become soiled. Gloves are not required by the Occupational Health and Safety Administration, OSHA, for vaccine administration unless there is the potential for exposure to blood or body fluids, the person administering the injection has open lesions on the hands, or it is an agency policy. Just remember, gloves cannot prevent a needle stick injury. You should never, ever detach, recap, or cut a used needle before disposal. All used syringe and needle devices should be placed in a puncture-proof container to prevent needle sticks and reuse. Used injection equipment should be disposed of as infectious medical waste. Safety needles or needle-free injection devices also can reduce the risk for injury and should be used whenever available. Here are a few more points about vaccine administration. It is not necessary to change needles between drawing up or reconstituting vaccine and administration unless the needle is contaminated or bent. Use a new syringe and needle to draw up each vaccine to be administered. When administering multiple vaccines, never mix vaccines in the same syringe unless they are approved for mixing by the Food and Drug Administration, and no attempt should ever be made to transfer vaccine from one syringe to another. Vaccines approved for mixing will be packaged together or indicated in the product information. If more than one vaccine is to be administered in the same limb, the injection sites should be separated by at least 1 inch if possible. This separation allows any local reactions to be differentiated. Vaccines that contain tetanus and diphtheria toxoids may cause more soreness than other vaccines, so you may want to give this vaccine alone or in the limb with a subcutaneous injection. We receive many questions about spacing of injections in a single limb. This spacing is a recommendation and not an absolute rule. Considering the number of injections needed at each visit in the first 2 years of life, there may be circumstances where separation of each site by 1 inch or more is not feasible. We are not aware of any evidence that less than 1 inch separation between injection sites reduces the effectiveness or safety of a vaccine. But you should try to put the most reactive vaccines, TD-containing vaccines, and pneumococcal conjugate vaccine into different limbs if you can. You should also develop a system so that everyone in your office administers the same vaccine into the same anatomic location. This way, if a local adverse reaction occurs, anyone can easily determine which vaccine is most likely to be responsible. A standardized vaccine administration map can help you do this. Here is an example of such a map. It suggests the anatomic area for each injection. This version was provided to us by the Michigan Department of Community Health in the Alliance for Immunization in Michigan. They have graciously allowed us to show it to you and to post it on the resources webpage. Please consider using this site map or one similar to standardize the vaccine administration procedures in your office. Aspiration is the process of pulling back on the plunger of the syringe prior to injection to ensure that the medication is not injected into a blood vessel. Aspiration is not required before administration of a vaccine. Although this practice is advocated by some experts and most nurses are taught to aspirate before injection, there is no evidence that this procedure is necessary. There are no reports of any person being injured because of failure to aspirate. In addition, the veins and arteries within the reach of a needle in the anatomic areas recommended for vaccination are too small to allow an intravenous push of vaccine without blowing out the vessel. A 2007 study from Canada compared infants' pain response using slow injection, aspiration, and slow withdrawal with another group using rapid injection, no aspiration, and rapid withdrawal. Based on behavioral and visual pain scales, the group that received the vaccine rapidly without aspiration experienced less pain. No adverse events were reported with either vaccination technique. A link to the study results is included on the Program Resources webpage. We have been downplaying the need for aspiration since the issue was first addressed in the 2002 edition of the General Recommendations. We have been impressed with the passion with which some nurses, particularly nursing instructors, defend this procedure. But I will repeat that we consider aspiration an option or preference, not a requirement. If you prefer to aspirate and blood appears, the needle should be withdrawn, the dose discarded, and a new needle, syringe, and vaccine dose used to administer the injection at a different site. One way to avoid the need to discard an expensive dose of vaccine and possibly minimize the patient's pain is to just not to aspirate in the first place. Andrew?
Many people, particularly healthcare personnel, claim to have latex allergies. Latex allergy is most often a contact-type allergy. There has only been one published report of an anaphylactic allergic reaction following vaccine administration in a patient with known severe allergy to latex. A person with an anaphylactic allergy to latex should not generally receive vaccines supplied in vials or syringes that contain natural rubber. Persons with latex allergies that are not anaphylactic, such as contact allergy to latex gloves, can receive vaccines supplied in vials or syringes that contain dry natural rubber or natural rubber latex. With the number of injections that we are giving in immunization practice today, both healthcare providers and parents are concerned about adequate pain control. Comfort measures and distraction techniques may help children cope with the discomfort associated with vaccination. Remember that pain is a subjective phenomenon influenced by multiple factors, including a person's age, anxiety level, previous healthcare experiences, and culture. There are a variety of measures that can help alleviate the pain caused by vaccination. Comfort measures such as distraction, ingestion of sweet liquids, breastfeeding, cooling of the injection site, and topical analgesia can help infants or children cope with the discomfort associated with vaccination. Pretreatment with 5% topical lidocaine-prilocaine emulsion can decrease the pain of vaccination by causing superficial anesthesia. Use of topical refrigerant spray immediately before vaccination can reduce the short-term pain associated with injections and can be as effective as lidocaine-prilocaine cream. The prophylactic use of an antipyretic drug, such as acetaminophen or ibuprofen, before or at the time of vaccination is not recommended, but they can be used for the treatment of fever or pain that might occur following vaccination. Studies have not demonstrated antipyretics to be effective in the prevention of febrile seizures. Another event to be aware of is fainting, referred to medically as syncope. This may have come to the attention of providers because most of our newest vaccines are recommended for adolescents. A CDC and FDA analysis of VAERS data indicates that females aged 11 to 18 years contributed most to an increase in the number of post-vaccination syncope reports. Although rare, serious injuries occurred. Although syncopal episodes are uncommon, vaccine providers should consider observing patients for 15 minutes after they are vaccinated to decrease the risk of injury should they faint, particularly when vaccinating adolescents. The person should be seated during this time. In fact, we recommend that you have adolescents and adults seated during vaccination and the observation period to decrease the risk of injury should they faint. Joellen.
We would like to end our discussion of vaccine administration with a few words about non-standard vaccination practices and vaccine administration errors. We have become increasingly concerned about the growing number of questions we are receiving asking what to do when the vaccine was given wrong, or the wrong vaccine dosage has been administered, or the wrong route was used. The first type of vaccine administration error is the administration of the wrong formulation. Since the approval of Tdap and zoster vaccines, we have heard of several instances where the wrong vaccine was administered. When young children receive Tdap instead of DTaP, they do not receive adequate amounts of diphtheria toxoid and pertussis antigens. This can place a young infant who has not completed a primary series of DTaP at increased risk for pertussis. If an adolescent or adult receives DTaP instead of Tdap, they are at increased risk for an exaggerated local reaction because they have received excess diphtheria toxoid and pertussis antigens. Even more concerning is when we hear about a young toddler receiving zoster vaccine instead of varicella vaccine. This exposes the child to a dose of vaccine virus 14 to 15 times the prescribed dose. Another concern related to administering the correct vaccine is using the correct diluent with the vaccine that requires reconstitution. We frequently receive questions about the effectiveness of vaccines when the wrong diluent has been used. Vaccine safety and efficacy data are based on using the prescribed diluent. Vaccine manufacturers and CDC do not test vaccine using the wrong diluent to find out what will happen. We almost always recommend that doses reconstituted with the wrong diluent be repeated. You must not only carefully check the label on the vaccines you administer, but also the diluent to ensure the appropriate product is used. Remember, standard medication guidelines require that a medication label is checked at least 3 times prior to administration. Similarity in product names and packaging also increases the risk of medication errors. We suggest that you do not store products with similar names or packaging close to each other in the refrigerator or freezer. A third administration error we hear about is the wrong route of administration. Earlier, we discussed several factors involved in ensuring that a vaccine is injected into the correct tissue. The first step in this process is verifying the route that should be used for a particular vaccine. For example, a common error we are hearing about is the inadvertent administration of meningococcal conjugate vaccine by the subcutaneous route. Meningococcal polysaccharide vaccine should be administered by the subcutaneous route, but meningococcal conjugate vaccines should be administered by the intramuscular route. We have also received several reports in which purified protein derivative, or PPD, used for tuberculin skin testing, and TD have been confused, resulting in intradermal administration of TD. Administration errors like these not only increase the risk of adverse reactions and suboptimal immune response, but they also diminish the trust and confidence that parents and patients have in their healthcare provider. Be sure that staff are adequately trained in standard vaccine administration practices and are oriented to the proper administration of new vaccine products. Remember, your patients are counting on you.
The success of efforts against vaccine-preventable diseases is attributable in part to proper storage and handling of vaccines. Vaccines exposed to temperatures outside the recommended ranges can have reduced potency and protection. Storage and handling errors can cost thousands of dollars in wasted vaccine and revaccination. They can also result in the loss of patient confidence when repeat doses are required. Vaccines are fragile and must be kept at the temperatures recommended by vaccine manufacturers at all times. It is better to not vaccinate than to administer a dose of vaccine that has been mishandled. Live vaccines can usually tolerate freezing temperatures. In fact, All vaccines that contain varicella virus must be stored in a continuously frozen state at the recommended freezer temperature until administration. MMR vaccine can be stored in either the refrigerator or the freezer. Live attenuated influenza and rotavirus vaccines must be kept at refrigerator temperature. Live virus vaccines deteriorate rapidly after they are removed from storage. On the other hand, inactivated vaccines are damaged when exposed to temperature fluctuations of either extreme heat or freezing temperatures. Inactivated vaccines exposed to freezing temperatures should not be used. However, they can tolerate short times out of refrigeration, although potency can be adversely affected if left out too long. Vaccines must be stored properly from the time they are manufactured until they are administered to your patients. The cold chain, which is a temperature-controlled supply chain, begins with the manufacturer and continues with the transfer of vaccine to the distributor, transfer from the distributor to the provider's office, and administration to the patient. Proper storage temperatures must be maintained at every link in the chain. All healthcare providers who administer vaccines must evaluate their cold chain procedures to ensure that vaccine storage and handling guidelines are being followed. Each office should develop and maintain a detailed written storage and handling protocol, assign storage and handling responsibilities to one person, designate a backup person, and provide training on vaccine storage and handling. Vaccine storage units must be selected carefully and used properly. Refrigerators without freezers and standalone freezers are preferred because they are better than combination refrigerator-freezer units at maintaining the required temperatures. Any refrigerator or freezer used for vaccine storage must have its own exterior door and must be able to maintain the required temperature range throughout the year. Whether using standalone units or a combination unit, each freezer and refrigerator compartment should have its own thermostat or temperature controls. It must be large enough to hold the year's largest vaccine inventory and must be dedicated to the storage of biologics. Food and beverages should not be stored in vaccine storage units. Keeping food and beverages in the storage unit leads to frequent opening of the door, which leads to temperature instability. Small single-door or dorm-style refrigerators like this should not be used to store vaccines because they are not capable of maintaining a consistent temperature. All inactivated vaccines require refrigerator storage temperatures between 35 and 46 degrees Fahrenheit, which is 2 to 8 degrees Celsius, with a desired average temperature of 40 degrees Fahrenheit or 5 degrees Celsius. Both types of influenza vaccine, inactivated vaccine and live attenuated influenza vaccine, as well as both rotavirus vaccines, must be stored in the refrigerator. All vaccines that contain live varicella virus must be stored in the freezer. Varicella and zoster vaccines should be stored at plus 5 degrees Fahrenheit, which is minus 15 degrees Celsius or colder. MMRV must also be stored in the freezer. MMR may be stored in either the freezer or the refrigerator. We recommend that you consider storing both MMR and MMRV in the freezer. This could help prevent inadvertently putting MMRV in the refrigerator. When MMRV and MMR are stored in the freezer, the temperature should be between minus 58 degrees Fahrenheit and plus 5 degrees Fahrenheit, which is minus 50 degrees Celsius and minus 15 degrees Celsius, because potency could be affected if the temperature is any colder. Also, if you are still using a combination refrigerator-freezer unit to store vaccines, be careful not to make the freezer so cold that the refrigerator temperature drops below the recommended temperature range. Andrew?
Proper temperature monitoring is vital to proper cold chain management. Temperatures should be checked twice a day, once in the morning and once at the end of the workday. Post a temperature log like this on the door of the refrigerator or freezer and record the temperature readings twice daily. Keep temperature logs for at least 3 years unless state statutes or rules require a longer period. As the refrigerator or freezer ages, you can track recurring problems or identify how long problems have existed. While it's important to document the temperatures, documentation is not enough. Equally important is taking immediate corrective action when the temperatures fall outside the recommended ranges. Remember, any mishandled or incorrectly stored vaccine should not be administered. It is especially important that inactivated vaccine that has been exposed to freezing temperature not be administered. If you discover that your refrigerated vaccine has been exposed to freezing temperature, even if the vaccines do not appear to have been frozen, you should segregate the exposed vaccine so it will not be used. Then contact the manufacturer or your state or local immunization program for advice. You should do the same thing if your freezer temperature rises above 5 degrees Fahrenheit during other than the normal defrost cycle. Whether you are using a combination refrigerator-freezer unit or standalone refrigerator and freezer units, both the refrigerator and freezer should have their own thermometer. Here are some examples of thermometers that can be used, including digital, biosafe liquid, continuous graphic, and minimum maximum. If you are using a continuous recording thermometer, even though it is recording the temperatures for you, it should still be checked twice each day to make sure the temperatures are in range. Thermometers are a critical part of good storage and handling practice. For measuring vaccine storage unit temperatures, CDC recommends using only calibrated thermometers with documented calibration measurements traceable to a testing laboratory accredited by the International Organization of Standardization, to the standards of the National Institute of Standards and Technology, or to another internationally recognized standards agency. Periodic recalibration is necessary, so you should check the thermometer manufacturer guidelines for further information. To maintain the proper temperature ranges, the refrigerator and freezer must be in good working condition and have power at all times. There are several things you can do to prevent problems. Storage units should be plugged directly into wall outlets. Multi-strip outlets should not be used. Your refrigerator and freezer storage units should have plug guards or safety lock plugs so that they cannot be inadvertently pulled out. You may want to install a temperature alarm to alert staff to after-hours emergencies, particularly if large vaccine inventories are maintained. Label the circuit breakers to alert janitors and electricians not to unplug vaccine storage units or turn the power off. You can do this by posting a warning sign like this near the electrical outlet, on the refrigerator and freezer units, and at the circuit breaker box. You can help stabilize the temperature in the refrigerator by keeping containers of water inside. This liquid bulk helps keep the temperature stable, particularly when the refrigerator is being opened and closed all day. If your refrigerator unit has vegetable, fruit, or deli bins, remove the bins and shelves and put water containers in their place. The same principle applies to the freezer. Store extra frozen packs or blue ice in the freezer. Not only will they help keep the temperature stable with frequent opening and closing of the door, but they will also help keep the temperature stable in the event of a power failure. Also, providers should never store vaccines in the door of the freezer or the refrigerator. The temperatures in these areas are not stable. Use these areas to store liquid bulk and frozen packs. We are frequently asked about storing biologic specimens, such as blood and urine, in the same storage unit as vaccines. We prefer that vaccines be kept in dedicated refrigerator and freezer storage units, but we understand this is not possible in some offices. If you must store biologic specimens in the same units as vaccines, be sure the specimens are stored on a lower shelf than your vaccine supply. This is to ensure that if a specimen leaks, your vaccine will not be contaminated. Joellen.
Another common inquiry we receive concerns pre-filling or drawing up doses of vaccine before they are actually needed. We strongly discourage providers from filling syringes in advance for a number of reasons. The most important reason is to avoid this practice is that filling a syringe before it is needed increases the risk for administration errors. Once in the syringe, vaccines are difficult to tell apart. Other problems associated with this practice are wasted vaccine and possible bacterial growth in vaccines that do not contain a preservative, such as vaccines supplied in a single-dose vial. As an alternative to pre-filling syringes, consider using manufacturer-supplied pre-filled syringes for large immunization events such as community influenza clinics. These syringes are designed for both storage and administration. Syringes other than those filled by the manufacturer are designed for immediate administration and not for vaccine storage. However, if you have a reason to drop more than one dose of vaccine, you should only pre-fill a few syringes at a time, and you should administer them yourself. Any syringes pre-filled by the provider must be stored at the recommended temperature range and used that day, or they should be discarded at the end of the clinic day. And one other point. When using manufacturer pre-filled syringes without a needle attached, do not activate the syringe by removing the syringe cap or attaching a needle until you are ready to administer the vaccine. Once the syringe is activated, the sterile seal is broken. If not used that day, activated syringes should be discarded at the end of the clinic day. Vaccine inventory control is a critical part of vaccine quality management. As a part of inventory control, providers should conduct a monthly vaccine inventory to be sure they have enough to meet their needs. However, avoid stocking excessive vaccine supplies. This leads to vaccine wastage when vaccines become outdated. Also include diluents in the stock control procedures and ensure adequate diluent supplies are available. Vaccines may be reconstituted only with a specified diluent. Diluents are not interchangeable except the sterile water used to reconstitute MMR, varicella, MMRV, and zoster vaccines. Providers should monitor the expiration date of their vaccines and the diluent supplies and rotate stock to avoid waste from expiration. Expired vaccine and diluent should never be used. It is critical that every clinic have a written emergency vaccine retrieval and storage plan. The most important part of this plan is to identify a backup location where the vaccine can be stored in the event of an emergency, such as an equipment failure or power outage. Considerations when choosing a site include appropriate storage units, temperature monitoring capability, and a backup generator. Consider contacting a local hospital, Red Cross, or long-term care facility as a backup site. Information to assist in developing both written and emergency plans are available in the Vaccine Storage and Handling Toolkit on the CDC Vaccines and Immunization website. Other helpful resources are available in the toolkit, including detailed storage and handling guidelines, forms, and posters. This is the main page of the online toolkit. There is also useful storage and handling resources in an appendix of the course text, including temperature logs, vaccine storage requirements, and warning signs for your electrical plugs and breaker box. In order for patients to be protected by vaccines, vaccines must be stored and handled with care. With a few simple steps and good practices to maintain proper vaccine storage and handling, we can ensure that the full benefit of immunization is realized.
We would like to present a case study that addresses issues that we have discussed on this program. The case studies are available on the Updates and Resources webpage. Aiden is 20 months old and is an established patient in your practice. Aiden received MMR number 1, varicella number 1, DTaP number 4, Hib number 4, PCV number 4, and hepatitis A number 1 at 14 months of age. Aiden's mother reports that he developed a temperature of 101 degrees for 2 days, about 9 days after the vaccines. He had no other symptoms and did not require medical attention. At 17 months of age, Aiden was diagnosed with a neuropathy that caused weakness of his left leg. He was treated with a 2-week course of prednisone and ibuprofen. 3 months later, he still has residual weakness of his left leg. He has no other medical problems. Here are the questions about Aiden. Was the fever 9 days after his last vaccinations caused by the vaccines? If so, which vaccine was responsible? Was the neuropathy caused by the vaccines? Should the fever and/or the neuropathy be reported to VAERS? If you are viewing this program with a group, we suggest you pause the program now and discuss it among yourselves. We will return in a moment to discuss it with you. The Aiden case study is a situation we hear about often. A person receives a vaccine, then a medical event occurs. The provider is uncertain about whether the vaccine caused the adverse reaction and what should be done about it. Here is the first question about Aiden. Aiden had a fever about 9 days after he received multiple vaccines. Was the fever caused by the vaccines? Possibly. Fever is not common, but can occur after almost any vaccine. If so, which vaccine was responsible? In this case, the fever was most likely caused by the measles component of MMR. MMR and varicella vaccines can cause fever 7 to 10 days after vaccination. The timing of the fever relative to the vaccine gives us a hint about which vaccine might be the cause. Fever after live vaccines occurs after an incubation period of the virus. Fever following inactivated vaccines usually occurs within 48 hours of vaccination. Here's the next question about Aiden. Was the neuropathy caused by the vaccines? Well, it's hard to say if the neuropathy was caused by the vaccines. Neuropathy of the leg has not been reported after vaccination. Brachial neuropathy has been reported after tetanus-containing vaccine, but is rare. Also, the neuropathy occurred 3 months after his last vaccines, which also makes vaccination less likely to be the cause of the symptoms. Now, here's the last question about Aiden. Should the fever and/or the neuropathy be reported to VAERS? It is not necessary to report the fever to VAERS. Fever is a recognized adverse reaction following MMR and varicella vaccines. However, the neuropathy definitely should be reported to VAERS. The main purpose of VAERS is to identify what are known as signals, clusters of cases of previously unidentified adverse reactions that should be reported. The neuropathy may or may not be related to the vaccine, but you don't need to know for sure. When in doubt, send in a VAERS report. What we would like to do now is share with you a few of the common questions that we receive on these topics. Joellen, I'm going to ask you the first one here. We hear this so much that many providers are concerned about giving live vaccines to anyone in the household with someone who's, say, on chemotherapy or has had a transplant, or even bringing grandchildren over to the house, you know, if someone's been, if the child's been vaccinated. What do we need to tell providers about this?
Well, that's a really good question, Donna. We get this one a lot. And what we have to think about is where is the risk associated to the immune suppressed person, because really that's the person who's the most vulnerable right now. And we're most at risk from someone bringing the disease to that immune suppressed person. So actually by vaccinating the close contacts, especially when we're talking about little kids, vaccinating them is going to protect the child and is going to protect the immune suppressed person also from them bringing the disease. So you actually get to protect two people with one shot.
It's that barrier of protection there.
Yeah, an extra layer.
Yeah, absolutely. Okay, thanks. Andrew, why is zoster vaccine not affected by